Hello, everyone. Welcome to the GSA Momentum Discussion webinar, Geriatric Oral Health and COVID-19, Old Problems, New Challenges, Part 1, Issues and Research Opportunities. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentations, and we will be accepting questions through the questions feature accessible on the GoToWebinar panel. Without further delay, I'll hand the microphone to Dr. Stephen Schuman at the University of Minnesota School of Dentistry.
Well, hello, welcome to a GSA Momentum discussion where we explore topics now experiencing momentum in the field of gerontology. Handouts with copies of slides are available from your screen. Today we have a 60-minute program starting with presentations by our speakers followed by a question and answer discussion at the end. And our sincere thanks to GlaxoSmithKline Consumer Healthcare for sponsoring our session today. My name is Steve Schuman. I'm director of the University of Minnesota School of Dentistry's Geriatrics program as well as chair of GSA's Oral Health Work Group. I'll be moderating this discussion of key issues, challenges, and potential opportunities in the wake of COVID-19, and it is my tremendous privilege to introduce our distinguished panel of interprofessional experts to you. Dr. Terry Fulmer is now president of the John Hartford Foundation. She is a GSA past president and also recently served as a member of the Federal Independent Coronavirus Commission on Safety and Quality in Nursing Homes. She's also been a leading advocate for geriatric oral health throughout her long and distinguished career in nursing and nursing education. Dr. Leo Marchini is associate professor in the Department of Preventive and Community Dentistry at the University of Iowa College of Dentistry, where he teaches geriatrics, conducts research, and provides clinical care. He is also chair of the Special Care Dentistry Association's Council for Geriatric Dentistry. Dr. Bei Wu is an inaugural co-director of the Aging Incubator at New York University, as well as Dean's Professor in Global Health and Director of Global Health and Aging Research at NYU's Rory Myers College of Nursing. Geriatric oral health is a major focus of her work, and she is also a member of our GSA Oral Health Work Group. Next slide. We'll begin our agenda today with Dr. Fulmer discussing the impact of COVID-19 on geriatric health and well-being. And then Dr. Marchini will then cover COVID-19 geriatric oral health issues, and Dr. Wu will then review emerging geriatric oral health research needs in the COVID-19 era. Following those presentations, we'll begin a 15-minute Q&A and discussion. Next slide, please. Since COVID-19 hit, many have pointed out that it laid bare and highlighted weaknesses already present in our elder care system. As far as oral health, it also reminded me of Maslow's hierarchy of needs that many of us learned in college and is so intuitively appealing that it never goes away. After many years of dealing with geriatric oral health barriers, it has always seemed to me that oral health had somehow wound up near the top of the hierarchy of needs for older adults, not only in long-term care, but for many in the community as well. Next slide. And when COVID-19 hit, it seemed like almost all efforts to address oral health needs in older adults were just about abandoned due to the fears about COVID morbidity and mortality in this population, along with the potential risks associated with dental care. So it seemed as though protection from COVID-19 got added to the bottom of the hierarchy of needs for older adults and completely bounced oral health out so that no one was thinking about it at all. And that is what drove our GSA Oral Health Work Group to try to address this situation, starting with these webinars. So, to begin our topic today, I will turn things over to Dr. Terry Fulmer from the Hartford Foundation. Next slide.
Thank you so much for the opportunity to be with everybody today, and good day to the audience and to my colleagues on this important panel. And I just want to underscore how important these seminars are to really remind us what is at the heart and soul of what we're trying to accomplish, and that's better care for the older adults we serve. Next slide, please. The John A. Hartford Foundation, inaugurated in 1929 through the generosity of the Hartford family with money from A&P grocery stores, has since the early 80s been dedicated to improving the care of older adults. And the way I like to explain it is we take the science and the evidence and get it into practice. We have 3 priority areas, and those priority areas include creating age-friendly health systems, because we do not have one currently. And an age-friendly health system is any point of care where the older individual is, maybe at their kitchen table, maybe in their dental office chair, maybe in their nursing home, but creating an age-friendly health system where you have reliable care that everybody understands and supports. Supporting family caregivers. We have 40 million family caregivers in this country, and so many of them, particularly during COVID, say, what do I do now? AARP has done a particularly good job with Home Alone 2.0, a wonderful paper that was developed by Susan Reinhardt and colleagues to really remind us of these 40 million people and the way that we are responsible to help them deliver the care they need in any point of care. And the example I'll use just to start us off is during this COVID crisis, when families could not go to the nursing home to help their family members or friends, there went the opportunity for somebody to check oral health, to brush someone's teeth, to be there for supportive care. So support for family caregivers. And then finally, improving serious illness and end-of-life care. Not synonymous, but certainly coupled, improving serious illness and end-of-life care. So if ever we had a serious illness, it is COVID-19, but most of the people who are in nursing homes or in long-term care or who are in their older years have comorbidities. We know in this audience that older people have 3 to 5 chronic diseases or disorders and are on an average of 5 to 10 medications. And so imagine managing that during the pandemic or at any point in time. So our foundation, our mission is to improve care, and we do it through these 3 priority areas, really working on implementation science. Next slide, please. So during COVID-19, what have we seen? Although less than 0.5% of the total population of our country live in nursing homes, as of September, these older individuals were disproportionately harmed by COVID. 40% of all deaths could be attributed to individuals in nursing homes, and 7% of all cases in the United States. This is as of September 16th, and we know that the numbers are even more dire now. So there we have disproportionate harm and a warning bell to all of us. Some of us would say we could have anticipated this. I'm one of those people, but here we are with the absolute mandate, ethical, moral, and clinical mandate to get it right going forward. Next slide, please. So what were the biggest issues facing nursing homes as COVID struck? All of my colleagues would say the following: staffing. We had staffing problems long before COVID-19 in nursing homes, but with COVID, staff became ill or were fearful and couldn't come to work or had to stay home to take care of other people in their network who were sick. So staffing, a critical issue during COVID. Infection prevention control. We know that nursing homes have always been responsible for infection prevention control, and that there are infection prevention specialists in some nursing homes, but not all nursing homes. But if there was any doubt about our need to improve infection control in nursing homes, we've seen it. Well, it's kind of hard to prevent infection if you don't know how. a virus spreads, and if you don't know how it's transmitted, which was what happened very early in not only Washington State, but New York State. As we learned more, we learned that it was imperative to have personal protective equipment. One of the issues that came up very quickly was that nursing homes did not have PPE. The way that our health system works is that we triage and we make decisions about who will benefit most from treatments and equipment. And we saw immediate triage to ICUs and to the acute care facilities. As someone who has worked in ICUs and acute care facilities, I recognize that, but we really abandoned the nursing homes and left them to create their own masks, do what they needed to do, and figure it out, which should never, ever happen again. Social isolation. With the closure of the ability of people to visit their family members or friends in nursing homes came tremendous social isolation for older adults. We've seen the heartbreaking renderings in videos and pictures of older adults looking out of windows to try to see people they love, or trying to figure out Zoom and FaceTime and all the other ways that one might stay connected. Most profoundly impacted were older individuals with dementia in nursing homes. People who can't understand why a mask is required, don't understand why they are being kept in their rooms, can't begin to navigate. So social isolation, not only for all nursing home residents, but underscoring those individuals, such as those with dementia, or even ALS individuals, people who have ALS, who could not possibly navigate their way to become less socially isolated. Finally, we saw racial and ethnic disparities. If you're in a community of color, you are more likely to have more COVID cases and more deaths. This is the equity lens that everybody in our country is determined to get on track, not only in the future, but today. American nursing homes, it's been said, are not designed, operated, or funded to deal effectively with infectious disease epidemics. And I say to you, why not? The NAM perspective paper that we wrote said that their staff are often too few in number, inadequately paid, inadequately protected, and without the requisite training they need to stay safe and keep others safe. So we can do this, and we need to do this, and this is what's in front of us. Next slide, please. What were our actions as a foundation? I'm very honored and proud to work with our Board of Trustees, where we called and we said that we needed to do things urgently and emergently. I was able to convene a group of national leaders in late March to convene and ask ourselves, what must we do immediately? And the question was, who's in charge? And we've seen that there's been little federal direction, but more agency by agency and state by state. So pulling together with a very distinguished group, it was clear to our foundation that urgently what we needed to do was fund the National Nursing Home Huddle, led by the Institute for Healthcare Improvement in Boston, Massachusetts, IHI, as a part of our age-friendly health system movement. And that work, which came with, that grant was about $300,000, has now evolved into the Nursing Home Echo program, COVID-19 Action Network series, funded by ARC for $255 million. That's what our board calls return on investment. Emergently, we funded the National Academies of Science, Engineering, and Medicine to launch a study on nursing home safety and quality post-COVID-19. The last time such a study was conducted was 1987, when we had OBRA 87. That study was very important, and I would argue every 30 years is insufficient. This study should be announced next week. It's on the webpage of the National Academies now, and the members will be posted next week. And then also emergently, we funded frameworks in Washington, D.C., led by Nat Kendall Taylor, to examine how to reframe the nursing home narrative. We saw headlines that said nursing homes are death traps. We saw headlines that nursing homes have been abandoned. Let's work with the evidence and knowledge that all of us have, and the science that GSA always generates, to understand what we need to do as a society to ensure that there is equitable quality care for everybody, regardless of setting. Next slide, please. So the disaster presents an opportunity to reimagine the role of nursing homes in healthcare for older adults, and this includes an opportunity to better incorporate oral health. I want to tell you all that in 1977, I finished my master's at Boston College, and my master's thesis was called Dentition and Nutrition in the Elderly. The thesis was, if you don't have teeth, you're not going to be able to chew and get your adequate nutrition. I've been thinking about this a long time. I was the dean of the College of Nursing at NYU that joined the College of Dentistry to do the oral physical connection of the entire body. And I have been working on this throughout my career. And I must say, if ever there was an opportunity to accelerate the change we want to see, it is certainly now. And I know that this panel has a lot of thoughts on this. Next slide. So the oral health is critical to healthy aging. We know this. I put this paper in just to remind you that I think about this for years, 1980, Dentition and Nutrition in the Elderly. And as a member of the Geriatric Oral Health Interest Group, your group really knows this better than anybody else. Next slide. During the crisis, we knew that oral health was impeded. Some older adults needed assistance with their daily oral care, couldn't get it. Physical distancing made it even that much harder. Regular professional care was needed, but really couldn't happen with keeping people from the dentist's office or keeping the dentist from joining us. And by the way, most nursing homes don't have these facilities. They may not have been allowing dental providers and students in. In the community, older adults do not feel comfortable with dental procedures at this time, and many who want care don't have access to providers. Next slide. So we've had dangerous impact, cavities not treated, respiratory infections, and all of the sequelae of diabetes, cardiovascular disease, pneumonia, stroke, and older adults in the community became less able to manage their daily activities, which necessitated increased levels of care and taking them out of their preferred homes. Very, very painful. Next slide. So in my last couple of minutes, we need policy change. We know almost 20% of older adults in the United States are affected by untreated dental decay. And by the way, when I started my career, that proportion, about 50% of older people were edentulous, no teeth, by the time they were in their 70s. So we've made progress, but not enough. The U.S. is still an oral health benefit under the Medicare, is still without an oral health benefit under Medicare. And about 37 million with Medicare don't have dental insurance. And even when older adults want care, they may not be able to afford it, with 10% of the total Medicare population not seeing a dentist in 2015 because of cost. And the cost of adding this basic and preventative dental treatment coverage has been estimated at $29 per beneficiary per year, and that's by Leinbach and colleagues. So I ask you, doesn't that seem like something we could do? Next slide. So building on the work and moving forward, my last slide, I wanted to say that I was a member of the Santa Fe group, a wonderful, what we call dental cognoscente group. Well, Mike Alfano and his colleagues invited me to participate and learned a lot about the multi-pronged strategies for addressing some of these policy issues. And we also funded more recently in 2016 the Santa Fe group to keep working on this. And it was really nice work that really kind of came to a screeching halt with this administration. So we want to keep on going no matter what we do, no matter what administration is leading in the White House, we can make a change on the ground. And I think the Oral Health Interest Group is taking this on. Next slide. It's my great privilege to represent the John A. Hartford Foundation with you today, and thank you. I turn it over to the next speaker.
Thank you, Dr. Fulmer, for that wonderful overview of COVID-19 impact on geriatric health and well-being. Now to address some specific oral health concerns we're facing, I'll invite Dr. Leo Marchini from the University of Iowa to take the mic. Leo?
Good morning, everyone. Thank you very much for inviting me to this presentation. And my talk would be focusing on COVID-19 geriatric oral health issues. So next slide, please. Older adults have a less efficient immune system and therefore are more susceptible to emerging infectious diseases, as we know. And early data showed that older adults were more at risk for COVID-19 infection. And in addition, older adults who have comorbidities were at an increased risk for fatal outcomes of COVID-19 infection. Next slide, please. So as a consequence of that, less attention has been devoted to the oral health care of older adults. So most oral health care for older adults has been related to chronic oral health problems rather than acute exacerbations. So older adults are less likely to suffer from acute oral health care problems during the current pandemics. But chronic oral health problems are likely to get worse during the crisis because caregivers are so focused on preventing of COVID-19 so that oral hygiene routines for residents may be further neglected, resulting in acute needs in the future. Next slide, please. So frail and functionally dependent older adults will face even greater barriers in trying to access oral health care than they already face now. As the most high-risk group for fatal outcomes of COVID-19 infection, this group of frail and functionally dependent patients and their guardians are likely to defer any elective oral health care procedure due to the fear of being contaminated with the COVID-19 virus. Dentists are also likely to recommend their older adult patients to avoid elective treatment until they solve the problem of aerosol control in their practices. Next slide, please. So for patients with urgent or progressing oral health care issues, new challenges will begin with obtaining appropriate consents from the patients, from their guardians and their caregivers for the recommended teletriage preoperatory procedures that we are supposed to do now to reduce the traffic in our offices. So, and right now, the teletriage preoperatory procedures are time-consuming, mainly when they involve guardians, caregivers, and they're not billable. So, not only we have the financial barrier, but teletriage itself is challenging, not only due to the persistent digital divide among the different generations, but also because many frail and functionally dependent older adults who have sensory and or cognitive impairments will find it very difficult to appropriately communicate through a telephone or a video call, even from what it concerns to the understanding and good usage of the technology. Next slide, please. So let's take one of the teletriage questions, the one that's related to the level of pain, which requires the patient to respond by using a scale from 0 to 10. Older adults tend to report less pain and have higher tolerance to pain. Therefore, the thresholds for triggering a dental visit using teletriage, which today is having pain on 6 or more in the scale, needs to be adjusted accordingly because it's not very common for older adults to report that type of pain. And letting alone that older adults with mild to moderate dementia are often unable to report the quality of their pain at all. And triage procedure need to be adapted for this group by including questions about nonverbal signs of pain and feedback from trained caretakers. Next slide, please. The next step after the teletriage for a patient to go to an office today is following the new norms for infection control, which are expected to be especially challenging for this group of patients as well. So let's look at the waiting room, where they need to maintain social distance, they need to follow cough and sneeze etiquette, and wearing masks may be from difficult to virtually impossible for older persons with dementia. This may result in an increasing demand for those patients to be treated in their own environments which has proven already to be very difficult for dentists to do in a regular basis, and being mainly by being not cost effective. In addition, if the person with dementia is currently living in a long-term care facility, it's likely that the facility may have restrictions for visiting by healthcare providers that are not part of their usual team. Next slide, please. So recommended PPE might also frighten older persons with dementia and also make it much more difficult to communicate with patients with sensory impairment, which are usually the majority of frail older adults, as they cannot lip read. Current restrictions in limiting escorts in the dental operatory will need to be lifted to allow caregivers to be present. However, those caregivers will also need appropriate PPE, which also increases cost. Next, please. Aerosol generating procedures, as we all know, should be avoided. So now it's the time to push forward for more conservative approaches for treating caries among frail and functionally dependent older adults. Mainly the use of silver diamine fluoride, SDF, and atraumatic restorative techniques, ART, such as using hanging instruments and glass ionomer cements, are likely now to become finally more routine. Next slide, please. For patients who are homebound and dependent, in order to avoid predictable increases in oral hygiene problems during this crisis, it is important to establish good communication with caregivers for homebound patients and patients in long-term care facilities. The best way to do it is using empathetic listening and leaning towards more compassionate care. The dentists and hygienists should be able to encourage oral hygiene routines to be maintained in spite of the current stress over the pandemic. And the only way to do that is by empathetic listening to the caretaker's concerns and fears, and guiding them through good routines to do that in a safely manner. Many caretakers are concerned about, brushing and generating more aerosol, which can be more contaminating. And that's one of the fears we have been listening to. So teledentistry can be an important, very important ally to encourage the maintenance of oral hygiene routines and even the ability to evaluate urgent oral health problems. Next slide, please. So when dentists can resume delivery of elective procedures, communication will be really key for ensuring a smooth transition to the new normal. When determining if a frail and functionally dependent older adult needs to have a face-to-face appointment, the clinician will need to decide where the patient should be seen and what should the patient and her caregiver expect during the appointment. Doing that using teledentistry tools has been very effective, and I think that can be also used after the current pandemic is over. This needs to be carefully considered. This needs to be carefully considered and explained to the patient and her caregiver before setting up the appointment. They need to know what they are going to face when they come to the dental office, or they also need to know how would that appointment be if performed in the long-term care facility. Next slide, please. So that's what I would like to add to the discussion, and I will be happy to answer questions. Thank you very much, and I am glad to let the next speaker take over.
Okay, Leo, thank you, Dr. Marchini, for that great review of key COVID-19 geriatric oral health issues. And now, for our last formal presentation, I want to turn things over to Dr. Bei Wu from NYU to address research issues.
Thank you, Dr. Schumann. Can you hear me?
Yes.
Yes. Hi. Good afternoon, everyone. It is my pleasure to join this panel to present the topic related to emerging geriatric oral health research needs in the COVID-19 era. So certainly that we see that the COVID-19 outbreak has elevated oral health care needs of the aging population. And many geriatric oral health research needs have been emerged during this crisis. So first of all, and we all know that COVID has greatly impacted dental care access in the United States, from closed offices to an increasing need for personal protective equipment, PPE. States and providers are both facing challenges to connect patients to dental care. So we're also aware that COVID has put our healthcare professionals at a high risk. Similar to nursing, dentistry is considered as one of the most high-risk occupations to virus infection. So based on some estimates, with high unemployment levels projected in the coming months, there's a major risk that demand for dental care could stagnate due to economic factors and also due to the fear of infection. So many dental offices have been closed. So based on this American Dental Association's estimate, it is that potentially COVID-19 has led to a 37% reduction in U.S. dental care spending in 2020. And the projection is that it will be a 20% reduction of dental spending in 2021. So, and this, that I have been studying geriatric dentistry and with the association between oral health and the systemic diseases, as well as the issue of regular dental checkups. So there's strong evidence shows that engaging in regular dental checkups can prevent oral diseases and promote oral health outcomes. So in this case, delayed or forgo dental treatment or prevented dental visits could have negative impact on oral health status of older adults. Next, please. Next slide, please. So here that I put this title as leveraging the COVID-19 crisis to elevate oral health care needs of the aging population. Some people may not particularly like the phrase I use here, leveraging, but in reality, that is to some extent the leveraging. We need to kind of leverage this COVID-19 crisis to elevate the oral health care needs of the aging population. We need to really to raise awareness of the importance of oral health, and also to think about how we can address these oral health care needs of the aging population. So one thing is clear, that the outbreak has exacerbated many oral health problems among older adults, as Leo said earlier, and many research questions also emerged during this period. So think about this. Probably these kind of research questions can be emerged at various levels, multi-levels. First of all, from biological mechanism perspective, while COVID-19 has a viral origin, it is suspected that in several cases, bacterial superinfections contribute to complications such as pneumonia and acute respiratory distress symptoms. So several mechanisms has been proposed to explain the role of oral bacteria in the pathogenesis of respiratory infection. So we need to look into the biological mechanism between, for example, periodontal disease and the COVID-19 infection. So just to give you an example, there's so many kind of research questions that can be elaborated here. But as a social and behavior researcher myself, I consider as a social and behavior researcher, I feel there's many research questions that we can address. For example, what is the impact of COVID-19 on the association between oral health and other physical and mental health outcomes? During and post-COVID, how do we work with older adults with physical and cognitive impairment, as Leo said again earlier, and also work with their family members to maintain or improve oral health status? Think about also from health services use perspective. We need to have more research to examine the impact of COVID on dental care utilization and oral health across racial ethnic groups and across different levels of socioeconomic status. It is likely that oral health disparities actually have widened in this country. We need to examine the relationship between dental care services with other health services, such as emergency visits and hospitalization. Next, please. From policy perspective, Dr. Terry Fulmer has elaborated a lot on the policy perspective. From policy perspective, so the co-located team-based comprehensive model of care has allowed for greater responsibility and flexibility with staffing, particularly with dental clinicians. So now it isn't uncommon for vulnerable populations to seek treatment for dental pain in an emergency room setting, which is costly and ineffective. The ability to provide access to a dental provider via telehealth emerging as a result of the pandemic may be worth maintaining long term. So there's also an opportunity to expand the use of telehealth for prevention and chronic care management. In many states, currently there's no reimbursement mechanism in place that allows dental providers to perform a risk-based oral health assessment, oral hygiene instruction, and nutrition counseling via a telehealth platform to help ensure maintenance of good oral health until they are able to have their next preventive dental visit. So there's really a need for reimbursement mechanism in place for teledentistry. It is also important to think about how we can actually build community partners to reach out to older adults from diverse populations. For example, underserved populations, low income, immigrants with limited English proficiencies, or these individuals. We need to pay more attention to how we can meet the needs of persons from that underserved population, as I said earlier. So the U.S. healthcare system is very complex, and the task of navigating the system can be daunting. So to some extent, just as an example, that we can use our lay community workers that can help patients navigate the healthcare system. They can also provide the cultural linkages. It can help overcome distrust. It can help contribute to and build patient-provider communication, and also can increase patient follow-up. Next, please. So certainly, as our previous speakers have said, I clearly see an opportunity to expand the delivery of teledentistry. But certainly there's many challenges and opportunities of teledentistry that we need to think about and that we need to address. For example, there's some actual measurement issues. Think about now, everywhere we go, we think about actually screening of COVID. But think about how the validity and the reliability of the skills of screening COVID-19 by distance, via actual virtual space. How do we evaluate the success and the effectiveness of teledentistry? And also, are our healthcare professionals prepared to deliver teledentistry in the future? So there's a significant need to develop a workforce to meet the healthcare needs of older adults post-COVID period. So telehealth and the teledentistry can potentially, we really have to be aware of this issue. Telehealth and the teledentistry can potentially widen the gap of health disparity among older adults And we certainly see this in right now in the period of COVID. So this actually, we're talking about how there's a big challenge for us to address with regard to how to address this digital divide in the nation. So let me give you some statistics. Langone Dental Medicine, they currently actually have this teledentistry service, but based on some statistics, what they found actually 16%, only 16% of African American patients use actually video conference via telehealth, while you look at 56% of Caucasian patients actually using video conference to receive telehealth services. So you clearly see that when we're talking about teledentistry, there's enormous amount of challenges facing us. Think about how many people that can have the access to reliable internet. Now today, I don't even actually dare to use this internet to deliver this presentation. I use actual phone, so I can actually ensure the reliable kind of delivery of my speech talk cannot be interrupted. So in this case, how many people will have smartphone, will have actually tablet that can actually to have receive this quality of teledentistry? So these are the kind of issues that we need to address. Next, please. So I think overall, there's many research opportunities emerge from this pandemic, and that I strongly encourage our research community to actually have more, and particularly young researchers, to actually get interested in geriatric dentistry and have more research actually in this field. Thank you.
Thank you, Dr. Wu, for that terrific review of emerging research issues. We've now reached a time where we have some time left to handle some question and answer and discussion with our panelists. I want to remind those in attendance that you can send questions using the questions feature that is located on the upper right side of your GoToWebinar screen. To get us going, I wanted to start with a question to Dr. Fulmer. It really feels as though COVID-19 has kind of set us back as far as awareness concerned about oral health, especially in long-term care facilities. What kind of prospects do you really see for more resources, more attention to this as a result of the pandemic?
Thanks for the question, Steve. And I think what we need to be focused on, maybe it's not more resources, but a different deployment of resources, and thinking about what are some of the things that we're paying for or doing now that are low value, and how do you make the case for high value care? And certainly oral health and disease prevention is high value care. Not to mention for comfort of older adults. If any of you have ever gone a day without brushing your teeth for some reason, multiply that. So I think that we need to create value and make sure that we are working smart in this area.
Okay, thank you very much. I have a question here too for Dr. Marchini, but I think it has come up with other speakers as well. The question is about teledentistry, and given the fact that you identified, Leo, some of the potential difficulties with telehealth and teledentistry in an older population, sensory issues, cognitive issues, technology issues, and I would add to that the staffing issues that Dr. Fulmer mentioned, which sometimes take away people who might be otherwise be available to help folks do a teledentistry or telehealth visit. Do you think we're going to be able to really overcome those challenges to make telehealth, teledentistry an effective intervention in the coming years following as a result of COVID-19?
Well, Steve, this is a great question. And I think it has multiple layers into this. Some of the layers were already touched upon. We have talked about, having staff issues. We have talked about having issues with the intergenerational divide on technology, which that means that usually older adults will have a little bit more difficulty with using the smart devices and tablets and things like that, as well as issues related to availability, as we just talked about beautifully. So those are some of the very objective layers into that. Another important layer is behavior, right? Is adopting it depends a lot on how we see it and how we behave towards it. So I would say that it would also be important to take into consideration the financial constraints. It is a very, teledentistry can be financially viable tool, but it also needs to reimburse the provider that's performing the teledentistry consult in a way that's attractive. So we should balance, the finance aspect of it and how people adopt the technology by creating intuitive, user-friendly platforms that also consider the cost balance to allow people to be more proactive on adopting it. Not sure if I was clear, but my intention was just saying that, we need to combine multiple approaches for teledentistry to become really not only having the potential to be used, but really being used by most providers.
Mm-hmm. And then following on that, of course, are the research opportunities. I think telehealth, teledentistry is just a new animal to a lot of us, and dentistry has always been seen as a procedure-oriented discipline where people came to our offices or we came to them to provide services. So it does look like there's a very fruitful opportunity for research into how best to make telehealth effective for oral health services. Dr. Wu, do you have any additional thoughts on that, on the telehealth research questions?
Yeah, I was just thinking about this, actually. Think about, again, to tap into, I was just saying about this digital divide, that need to be careful about how we actually to address this issue. It's a huge challenge. And we know that oral health disparities that actually certainly reflect the most challenging issues that our nation faces. Think about access to care, think about financial resources, think about all these socioeconomic status. So that how we can now this tele-dentistry, we certainly need more innovative approaches. That again, to think about how our train our healthcare workforce to be ready, to be more actually competent to deliver these kind of services, as well as think about how we can train our older adults to use technology. Not only that, actually from a tech point of view, that how we can think about generate age-friendly technology. Now, I know Dr. Fulmer and others are very much into this age-friendly health system, but also think about how we can actually to have input of our older adults and the family members into these kind of apps that right from the beginning, how we can actually ask their input to develop these kind of apps to be more friendly for older adults. with kind of visual impairment, with the sensory loss, persons with sensory loss. So, and also for persons with cognitive impairment. So this is it is a multiple kind of ways. Need to have multiple approaches to address this issue. Again, then the payment issue, right? So from policy and the payment issues that now so far that Medicare still has very limited dental coverage or none dental coverage. Now it's time for change. How we can improve to integrate dental care as part of the integrated healthcare system, delivery system.
Thank you. Yeah, and we do have a comment in from one of our attendees about just the challenges, the overriding challenges the older population still faces due to a lack of dental insurance, and you know how the population will pay for services regardless of what we make available. I know Dr. Fulmer talked about the movement toward and the interest in Medicare, a Medicare benefit. Any additional thoughts from the panel on that issue of coverage and the lack of insurance?
I think I can start taking an initial step on that. I think we should, well, first of all, I think we should act at the societal level, and as dentists and our institutions, our associations should advocate for inclusion of dental procedures on Medicare. I think it's a very controversial topic for many, so it's not consensus among us yet, but I think that's one way to provide more people with more access. Then there is what we should do, what can be done in the local level, right? In our provider level, by setting up reasonable fees that would consider your local reality, which would take into consideration your local economy and the population you deal with. So I think those are starting points, but I would love to hear from the other panelists.
Any additional thoughts from our other panelists?
Yeah, I think about actually Medicare expansion. I think probably the first thing to begin with actually is for dual eligible person. Think about Medicare, Medicaid beneficiary. These are probably the individuals that need the help the most. So start from that, then kind of before we kind of the overhaul of healthcare system takes a huge effort, but certainly can start from those most needs of the needed help for dental care.
Okay, thank you. We're coming up with just a couple of minutes before we need to start wrapping up. I have another question here from attendees. In providing direct care in a long-term care facility, what are the most important tools or needs for that visit or appointment to prevent disease from the point of view of professional intervention? Now, I also want to make sure that everybody out there knows we have a follow-up webinar next week, same time, same station, to talk about case studies, to talk about real-world examples of what's going on in the world of COVID-19 and geriatric oral health care. But I think, do we have any thoughts in terms of providing direct care and long-term care about what the most important tools or needs for that visit would be at this point?
Sure, it's Terry. I'll take that. The first thing is make sure you're tested before you go into a long-term care facility to protect yourself and protect others. Make sure you have appropriate PPE and that you are absolutely up to date on infection prevention control so that you can be rigorously ready to participate with that organization. Also be aware whether your neighborhood, the area in which you live, has had any COVID outbreaks. Work by Vince Moore and Dave Grabowski have made it very clear that the vectors for infection are people coming in and out of the nursing home building or the long-term care building. And so making sure that you're aware of what's going on in your neighborhood, that you know your own health condition, that you have PPE, you know infection control, you're taking your temperature on a regular basis. And then also that the staff on the other end know you're coming. I know that sounds silly, but they don't. And make sure that they're ready to receive you so that you show up at a time when the older person is rested, is emotionally and physically prepared to receive you as a clinician. So often we do things at our own advantage. We do things that are convenient for us, and that has to fundamentally change. If we're going to do patient-centered, goal-directed care, and we focus on the 4 M's, and the first M of the 4 M's of age-friendly is what matters to the older adults in their family. So what matters is making sure that you have given them the appropriate planning, the safety plan, and also that they are emotionally ready to receive you for care.
Great. Thank you for that final word on our discussion. I now want to thank our speakers again from the bottom of my heart, really, for their thought-provoking presentations and the discussion today. I also want to offer special thanks to GSA's team that helped put all this together. That's Karen Tracy and Michael Posey and Judy Liu for their support in managing this webinar series. Next slide. Can you go back to I think we have time. Yep. I just wanted to share this with you as we close today. I think in difficult and stressful times as these, it can help to turn to the arts for consolation and perspective. And in that spirit, I wanted to share a poem first published this past May in the New York Times as part of a collection of poems about the pandemic. It was written by N. Scott Momaday, a Kiowa novelist, short story writer, essayist, and poet. And his novel, House Made of Dawn, won the Pulitzer Prize for Fiction in 1969 and is considered the first major work of the Native American Renaissance. The poem is, in the time of plague, we keep indoors, we dare to venture out. When we dare to venture out, we are cautious. Our neighbors smile, but in their eyes there is reserve and suspicion. They keep their distance as we do ours in mute accord. Much of our fear is unspoken, for there is at last the weight of custom, the tender of rote consolation. We endure thoughts of demise and measure the distance of death. Death too wears a mask. But consider there may well be good in our misfortune if we can find it. It is hidden in the darkness of our fear, but discover it and see that it is hope, and more, it is the gift of opportunity. We have the rare chance to prevail, to pose a resolution for world renewal. We can be better than we have ever been. We can improve the human condition. We can imagine then strive to realize our potential for goodness and morality. We can overcome pestilence, war, and poverty. We can preserve our sacred purpose. We can determine who we are in our essential nature and who we can be. We are committed to this end for our own sake and the sake of those who will come after us. There is a better future, and we can secure it. Let us take up the task and let us be worthy of our best destiny. Next slide. I want to remind our participants today of the upcoming meeting next week. That's next Tuesday, the 13th from 4 to 5 for our GSA Oral Health Interest Group. And then I also want to strongly encourage you all to tune into part 2 of this webinar series on case studies, which will be next Friday, October 16th from 1 to 2 p.m. Eastern Time. You can register for both of those on the GSA website. And now I will turn things back to Judy to close us out.
Thank you, Stephen. I just want to share with the audience, please also join us on November 4 through 7 at the Gerontological Society of America's Reimagined 2020 Annual Scientific Meeting online. The meeting will be hosted on a state-of-the-art platform, and should offer an immersive experience, allowing you to focus on essential research and networking. Please know a webinar survey will automatically launch after the webinar. In an effort for continual improvement, we would like to hear your thoughts. So please provide feedback by clicking the survey link at the end of the webinar. And I am afraid we have run out of time, but a big thank you to the panel, the participants, and our webinar sponsor, GlaxoSmithKline Consumer Healthcare. This is the end of the program.